Hi, I'm Dr. Joy, a board-certified emergency physician, and I am so incredibly honored to share this bonus episode with all of you as part of my #WeWon'tQuit mini-series in collaboration with American College of Emergency Physicians, otherwise known as ACEP. If you are an emergency physician like me, ACEP needs no introduction. For those who are less familiar, ACEP is the primary professional organization for emergency physicians in the United States. One of ACEP's core values is that the physician-patient relationship is the moral center of medicine and must never be compromised by corporate, government, or financial influence. In the 16 years since I began my career in emergency medicine, I have had the privilege of working alongside innumerable colleagues who embody this core value. In this special bonus episode, I am honored to present the following stories told by my friends and colleagues as part of ACEP's Answering the Call campaign. If you are an emergency physician attending ACEP 2025 in Salt Lake City with us, please stop by and pick up a phone at the Answering the Call installment to share your story too. Your voice matters, and through conversation, we can make healthcare better for all of us. And now it's time to shine the spotlight on my colleagues, starting with Dr. Rachel Thomas, whose career in emergency medicine began with residency at a Level 1 trauma center in Tucson, Arizona, followed by community emergency medicine in Idaho, and ultimately landed her in New Zealand, where she rediscovered her love of medicine through human connection.
One that stands out to me that just is one of those heart moments that go, okay, this is why I do this job. Here in New Zealand, had a younger middle-aged gentleman who came in for headaches. And based on kind of traditional headache workup and evaluation, no significant red flags. But after all the years of doing this, as we all know, as we do this longer and longer and longer, something wasn't sitting right with me. I don't know that I could even put my finger directly on what piece of the story, but little bits and pieces of his story that just made me say, I feel like maybe something more is going on. He'd had the headache for over 6 weeks, while never debilitating, becoming more frequent. I think some of the things that stood out is seemed to be worse in the morning and some just little things, but no neurological findings or complaints. And I had a big talk with him. And I said, normally I wouldn't image someone like you, but I think for some reason I just feel like we should. And I explained the risk and we talked about it. And he's like, actually, doc, I feel like something's going on. I really appreciate you listening. Because he's a pretty stoic, very traditional of this area, farmer type guy. So the fact he even came into the emergency room to me said something's going on. An image just said he had actually a pretty large tumor, large enough to see on the non-con CT. I live on this northern tip of the southern island of New Zealand. And oftentimes we end up flying patients just over to Wellington, which is just across the strait. And I spoke to the neurosurgical team over there and set him up to go. And I went in to have that conversation. It can sometimes be the toughest conversation. Hey, you're a pretty young guy and you've got this finding. We don't think it's cancerous. We can't say for sure, but it's large enough. It's starting to cause problems and you need to have it surgically removed. And there's risks to this surgery. The surgeons will talk more to you about it. But at this time, this is what we're going to do. And poor guy, he was like, I left a bunch of stuff at a work site in my truck. And the other nice thing about New Zealand is it's like, do you have family? No, I don't really know anyone here. I'm like, okay, well, if you want, myself and the nurses, we can go pick up your stuff. We're happy to go grab it. And we have, again, socialized medicine. So we have our public hospital, but there is a private hospital kind of connected. Well, he actually knew the guy in charge of the radiology department at the private hospital who came over and he's like, Rach, don't worry about it. I'll go grab his stuff. So we're chatting and he looks at me, he's like, Doc, I just really want to have one more smoke. And I'm like, okay, but you got to stop smoking. And we had the talk. He goes, Doc, I promise you, and I'll prove it to you. This is my last cigarette. I'm like, okay, I'm going to hold you to that. And had this tough talk with him. He goes, Doc, you found the answer. We at least can start addressing it. And there was just this I understand it's serious, but I'm going to take a positive outlook on it. And it was just this really good interaction. So he gets wheeled away. And I normally am not someone who would ever allow a patient on social media to friend me, but he sent me a message on social media. It's again, small town, so it's not hard to find. And he just said, hey doc, I hope this is appropriate and I promise not to bother you further, but I want to make sure you heard my surgery went great. I have no deficits. I truly feel like you saved my life because I think if you had sent me away, I would have just continued to ignore it. And I'm going to be fully functioning. He goes, and I haven't had another cigarette. And about every month I get an update from him. I've been swimming 3 times a week. I can now do this hike that I couldn't do before. I still haven't had a cigarette. And so just seeing this positive impact that we can really make if we just listen to our inner dialogue and our inner gestalt, but then at the same time listening to the patient and reading the patient. This guy wouldn't be here if he didn't think something was wrong. And saying, I'm a bit worried. He goes, good, because I am too. And he finally felt comfortable voicing that. And so that's one that's really stuck with me. And it gives me that, okay, I do good. I do some good in this job, and I can make a difference still, because there are days that it's tough and you feel like you're just stuck in the grind and it doesn't feel like you can make that difference anymore, or you lose sight of it a bit, right? You're like, oh, well, that's not a big deal. I do that every day. Yes, cool. We caught that appendicitis, or we set that bone. And those are still important things. But I think as we do this longer and longer, we don't get that same, oh, good, I'm making a difference feeling as much. And so it's good to have those moments. I have found I've been really lucky with my new role here in New Zealand, and it's made me love medicine again, because I did hit the burnout, and I did hit that at the 10, 11 year mark. And I let myself work too hard and be pulled into too much. And I am a big contributor to my own burnout. So there's nothing I could say negative about where I was working with the group I was working with, but I felt it. And I remember looking at my husband and saying, I think I'm done with medicine. And bless him, he looked at me and he goes, okay, are you done with medicine? Are you done with medicine how you're practicing it now? And I looked at him and I said, I don't know. I'm not sure. And that's when he said, hey, we've talked about living internationally. We've talked about New Zealand. What do you think about going to work in New Zealand for a year and seeing if you still love medicine or not? And I have found my love and my passion for it again. And I think the biggest contributor for me to that is I have more time here with my patients. And this could be done in the US too. You don't have to move to New Zealand for this, but you need, it's finding that world where you can find that balance, where I was seeing 20 to 30 patients in a shift, in an 8-hour shift. And when you're doing that, those are all people who need you, but you don't have time to build any sort of rapport or relationship. Here, I get more time with patients. I volunteered at a fundraiser this last week, and a woman walks up to me, she goes, you look familiar. And I'm like, well, these are some of the places you might know. She goes, oh, I remember I danced myself right out of my hip and you put it back in. And it's just these connections, and giving yourself time to make those connections, those true human connections, makes me love the job so much more, because I still love the medicine. I love the science and the pathology and the detective work in emergency medicine. It's why so many of us chose it, right? Going from trying to solve these puzzles and dealing with emergencies and finding all of that balance with all these different things, but we also still love the human interaction and the human component. And I think where a lot of our burnout comes from is losing the ability to spend more time within that human component of it.
The need for emergency medical services is universal across countries around the world and in both urban and rural communities. Dr. Steve Grokey has found meaning working at a small critical access hospital in the mountains, where resources are sometimes scarce, but his emergency medicine training can bridge the gap.
Big Bear is what they call a critical access hospital. To keep it simple, it's just a small little hospital out in the community. There's no specialists. I am the doctor in the hospital. You don't have too many people you can call if something's going wrong or you need help or backup. And that's one of the joys of that job is it's just you. And so you get a lot of practice doing different procedures. It pushes your comfort level. You might be delivering babies, which has been done quite a bit up there, and there's no OB doctor right there to help you if things get in a bind. So you don't have backup. You are the doctor, and some patients are not safe to be there. You've got to get them to a bigger hospital where the specialists are, and you got to deal with, do you have an ambulance available? Do you have a helicopter that can fly in the weather that in Big Bear it snows a lot? And so that limits your ability to quickly get patients out of there. And sometimes that's one of the challenges we have to deal with. I like the big hospitals because it does offer a little bit of comfort in having backup and help. And so you can walk into a shift and say, okay, no matter what happens, we as a team can get through this. But at the same time, I like the small hospitals because of the challenge. And then there's a little more camaraderie in a small hospital when you don't have those resources and you're like, okay, team, it's the 4 of us. I'm used to having a team of maybe 20 people in the department. Now I have 4 people as the nurses and techs, and you grow closer together. I think when it's a small unit like that. I was working up in Big Bear one day, and this old guy came in complaining of abdominal pain, and he passed out. And that was it's something you hear about in textbooks, and I kind of my mind went straight to what I feared the most, and I put an ultrasound on his belly, and sure enough, he had a large abdominal aneurysm that ruptured. So yeah, I have the diagnosis, and I quickly got him over to CT scan to confirm, but I put in the request to start to get him transferred, and of course it's winter and bad weather, and we had the obstacle we couldn't find a receiving hospital, and we had to go far and wide, go out to I even tried Palomar, and they told me, we're too far, something might happen en route, so please try to find somebody else. And ultimately, I had to go to Irvine, which is far away. And then we realized we can't fly this patient; the weather's not good enough. And so hours into it, his blood pressure's crashed, and we're giving blood. We finally got an accepting facility, got an ambulance that could drive him, but it's still a far drive. But we ultimately able to get him there. But it's just one of those, everything that could go wrong went wrong, but we still got him there in one piece. But that's the story that kind of said, you are making a difference. This case could have gone different directions, and we ended up saving this guy and getting him transferred out. There were some obstacles along the way, but that's the story that sticks with me. What keeps me inspired is when I can connect with a patient. It can be a busy shift full of frustrations, but if I find one or two patients I can just sit down with, just chat with them and just connect, something that we don't always get to do in the emergency room. If I can do that, it just kind of refills me, gets me through the end of the shift, gets me looking forward to the next shift. If I can just have that one good solid touch point with a patient.
Whether at a small critical access hospital with single coverage or at the largest hospital in San Diego County, where multiple emergency physicians work side by side to care for hundreds of patients per day, as Dr. Dan Meltzer would say, it's not always about what you do, it's how you do it.
I was chief and chairman of emergency medicine at Kaiser Permanente in San Diego. I worked at KP in San Diego for 16 years. Really enjoyed my clinical practice there. We were, at the time, the busiest emergency department in San Diego County. We had one emergency department. We were opening our second. We had a residency training program with ultrasound fellowship trained physician as well as toxicology trained physicians that helped support it, and a wilderness medicine physician as well. So we had, at the time, 72 full-time physicians, about 350 nurses, and about 20 APPs. I think there are cases that we carry with us. Some make us perspire, perhaps more than feel inspired. And, I think whether it's often, children, frankly, I think we remember a lot of the sick kids or some of the traumatic injuries that we've seen. I was a flight physician for 3 years as part of my training, and there's certainly some flights that I will never forget, whether it was landing on a beach or a freeway or a sand dune or the side of the mountain. There was a case that I had very early on in my attending career, not to date myself, but too late, probably early 2000s. And I had some ultrasound training in residency, but when I started working as an attending, it was not really that well deployed. And from my training, my skills were such that most of the central lines that we did were done the old-fashioned way, sort of by anatomic evaluation. And I'll never forget a patient that I had. She came in with a neutropenic fever and sepsis and had a fair bit of radiation to her chest wall and her neck. It was very difficult to get IV access, and she was profoundly dehydrated in hypovolemic shock. And I ended up doing what we don't do as much anymore, but was a femoral line, and it was just incredibly hard to get access on her. And as I was, continuing to sort of palpate and look for the flash that we love to see, I just felt like I was frankly hurting her. Despite anesthetic that we may try to provide, it's not a pleasant procedure, as we all know. It's a pretty sensitive area, and I think it was probably fairly self-evident that things were not going as quickly or as easily as we would have liked. Obviously, I continue to explain what we were doing and why, and appreciated her patience and partnership. But when you're draped and you're not feeling well, and you already have cancer at baseline, and now you've got a fever, and you're just trying to maintain a blood pressure for us. But yeah, I felt badly, and I felt like she was probably uncomfortable despite my best attempts. And yet she, willingly obliged and allowed us to continue to do our job and work as a team. Eventually I was able to get access and resuscitate her. She actually wrote me a thank you card, which can be really rare, but she wrote me a thank you note that said, "Thank you for saving my life." And I kept it in my office on a bulletin board for probably at least a decade. I did not feel, candidly, that I was saving her life at the time. I felt like I was torturing her. And what struck me was the difference between her perception and mine. her perception was that I was trying to save her life, and in my perception was I was torturing her. And I think it served to remind me that the work that we do, and it's not necessarily what you do, it's how you do it. It's a little bit around the Maya Angelou quote. People will not remember necessarily what you said, they'll remember how you made them feel. And so obviously, despite feeling bad in her minds, she was grateful that we were working hard to resuscitate her. And indeed we did. So that's one case that I think kept me very grounded to purpose and perspective. I feel like empathy may be an overused term these days, although I think it's probably an under-displayed trait. And I think a lot of medical training sort of teaches us to kind of not be vulnerable, to sort of suck it up and maintain objectivity. And yet when we do that, we actually probably deprive ourselves of exactly why we went into this field, which is to connect with people and try to make them feel better. And that doesn't mean that we're, busting a tear and hugging it out at the bedside necessarily, although at times that may be appropriate. But I think it does mean that if we can connect back to what hopefully was that humanistic drive, not only do the patients feel better, but I think we do too. I kind of go back, believe it or not, to my medical school essay from time to time, which I remember writing with my father, who's a physician. And I talked about medicine as a noble profession, and I still believe that it is. I talked about it as a scientific discipline, which I definitely believe that it is. And I think it's more important than ever that we retain that scientific validity and methodology. And I talked about it as a humanitarian pursuit, and I think it still is as well. And so, a noble profession, a scientific discipline, a humanitarian pursuit, I still find that compelling. Despite the noise, when we're at the bedside, we still have influence over what transpires there. We still have a high degree of autonomy and purpose and the ability to leverage our mastery. Hopefully there are minutes and moments where we can connect to that. I think it's still there. It's still there for the taking if we can remind ourselves and focus on it.
Dr. Dan Meltzer describes the medical field as a noble profession, a scientific discipline, and a humanitarian pursuit. And in the next story, Dr. Jeff Lapointe reminds us of what that humanitarian pursuit really means. It means we show up to help, and when someone is in need, we never say no.
We all have all these stories. Like that's kind of like a core thing of our specialty, right? But I think the one that sticks with me the most, not so much for what I did, but just kind of what it means is I was a toxicology fellow and they don't pay us real well. And we were living in New York. And so I was moonlighting in like any little place in New York that I could. And a lot of those places aren't trauma centers. And one day in the middle of the morning shift, a 15-year-old kid jumped in front of the G train in Brooklyn. And EMS just brought this kid in and they had no legs and were missing their right arm. Bilateral lower extremity and upper extremity amputation. The vitals were terrible. Medical care that I gave wasn't, state of the art, or I don't think it would impress anyone in a case review or a trauma M&M, but just the getting tourniquets on and giving some blood. There were difficulties in the transfer, like that system wasn't set up for a trauma transfer like that, or in that moment. The people at the front were kind of like, well, this isn't a trauma center. So I ended up just getting in a BLS rig with just me and an EMT, and I had a manual blood pressure cuff as we raced across the Manhattan Bridge, and it was just like, I was really scared. I was terrified, but that's not, we just don't say no, and you just kind of jump in and do what you think needs to be done. And then actually took the kid to Bellevue where I was a fellow, and the kid survived. I had some follow-up from some of the residents that were at Bellevue about the case, and I didn't do much, and it's less about what I did and just more about what we're expected to. It always reminds me that it doesn't matter the resources. It doesn't matter that you're not a trauma center. It doesn't matter that you're not a STEMI receiving center, or you don't have ECMO, or you might not have nephrology. Our specialty is defined by that contract with uncertainty. We don't say no. We always say yes. It doesn't matter what comes in. It doesn't matter what you have or don't have. And that sets us apart literally from every other specialty. That kind of contract with unpredictability and uncertainty, where you're asked and demanded to make decisions with little info and less time. So whenever I walk into the ED every day, I'm like, what is it going to be today that is going to challenge me, or that I might not be ready for, or I might not have the backup for, right? We don't always get to practice at like quaternary referral centers in everything. And so I think that that's what really sets us apart and makes us unique. We never say no. Like, my difficult airway protocol doesn't start with, are they NPO, and end with, well, cancel the case. Like those things that everyone else can rely on, like, it doesn't matter. We just jump in and do the thing and get the patients what they need. And so regardless of who they are or where they are, what their complaint is, or what insurance they have, that's the thing that always sticks with me the most in emergency medicine. I think that going into it, I would say that I should have listened less to what people outside of the specialty have to say about it, and listened more to what people in the specialty who do it say. Because I really get now that the rest of the house of medicine doesn't get us. It doesn't know what to do. We don't fit in the construct of how they build their day or their life. And it is that inherent bargain with unpredictability or uncertainty that they can't get. And so, my father's a physician. My father's a retired orthopedic surgeon in the Navy. He kind of gave me that jack of all trades. But that's not true. We are the ace of one trade, and that's the worst 10 minutes of everyone's trade. It's a beautiful, wonderful, hard, heartbreaking, worthy specialty that if I could go all the way back and say, do it again, yes or no, 15 years or whatever later, the answer would be yes, unequivocally.
It is never lost on us as emergency physicians that the people we take care of often come to us in their most vulnerable state, putting their trust in us to navigate them to safety. And as Dr. Neil Aaron reminds us with this next story, that trust which is given to us by the people we care for is not taken lightly. Trust is a gift that comes with immense responsibility.
Definitely a lot of stories that I carry with me, and you sort of lean on in those times to remember about why you went into medicine. When I was an undergrad volunteering doing medical work down in Mexico, we were in a really rural town in Mexico that's isolated from everything else and was still working on getting running water. So to kind of paint the picture, we were there to do anything and everything we could. And we showed up really not knowing what they would need or what resources they would have. During the day, we did general clinic stuff and penicillin and teeth and wounds and lots of horse-related traumas. But there was a particular case where sort of at the end of the day, I think we gained the trust of the community, and they brought us to a little house, and there was a hut off the side of the house, and they were kind of not saying much on the way there. And when we got there, there was a early 20-year-old male who was inside this hut that looks essentially like a porta potty made from wood, and he was in chains. And the story goes that he had probably schizophrenia and would have hallucinations and had attacked his mom and actually significantly hurt her physically. And so the town didn't understand what was going on with him, and they had no insight into what could be causing his hallucinations or why he would act like that. They presumed he was possessed by some spiritual being, and so they chained him into this room. And the mom lived 10 feet from that hut, and she still loved him very much, but she had no idea what was going on. And there's a lot of layers there, but we were able to, make some headway on helping them getting some medications and some medical care for the son, providing a better future for him and some insight into the current condition. Just the fact that we were able to experience that, I think, went a long way to open my mind to just this level of trust that comes with the profession and the ability to have people that you just met share with you their deepest, darkest secrets. And to this day, I'm very thankful both that I got to see that aspect of medicine and that I continually get to meet people from all different walks of life on a daily basis and meet them where they're at and experience their life with them and often be an integral part of that and hopefully make their life a little bit better. we have a unique opportunity to continue the advancements and just the openness that we have in mental health. Definitely, we've come a long ways, and we still have a long ways to go. I think it's a really good insight into the lack of resources available, as well as an opportunity to be an advocate for our patients and fight for them to get resources and to get the appropriate treatment, as well as breaking down the stigmas that exist and just welcoming people with open arms in whatever condition they're in. Right? That's sort of the mantra of emergency medicine is we got to be available at all times of the day, all days of the year to treat anything and everything that walks through the door and do so with no judgment. That's sort of the beauty of our job. You're going to be tired. There's going to be days when you have your own financial family stress with health, and when you're at your weakest point, sometimes you have to show up to work and really give your all to your patients, and they deserve that, right? And so I think falling back on your why, that's going to be the most important thing in those times when you don't have the strength. The problems in healthcare are huge, and there are, political, financial, all sorts of incentives that other people have. But at the end of the day, it is really the pure medicine of being able to show up and take care of people and meet people in often their darkest hour. And I think reflecting and talking about it with each other is taking that moment to look back and have gratitude of the opportunity we have, because we definitely get down to the grind every day, and sometimes life is going fast and we're involved in the stressful situations, but to sit back and reflect on what is our why and why we went into this in the first place really helps, I think, center you and remind you that it's worth the cost.
Being an emergency physician is not easy for many reasons, one being the gravitas of the trauma we bear witness to. Dr. Melissa Zukowski reminds us to lean into our colleagues, our team, because the people in the trenches with us are a tangible and continuous source of inspiration.
Emergency medicine became harder, and pediatric emergency medicine became harder when I had my own daughter. I think, everything becomes more real and you're kind of much more in that moment. I think the patient that really sticks in my mind, it's not the happiest of emergency medicine stories, but a few years back, we actually had a child come into the emergency department that we were actually very worried about non-accidental trauma. And the reason that it really inspires me is that, this little girl was in a very vulnerable state, couldn't speak for herself. And to see the emergency medicine team, the trauma team, the abuse team that we're lucky to have here all come together and really rally behind this patient to really have all hands on deck and really take care of her to the best of our abilities in that moment is just something about emergency medicine that I really love. That little girl in that story is just always one that really touches me, that we're there when people need us most. Just knowing that in that moment, there were, X amount of adults and caretakers who were putting all of their heart into that little person at that moment in time really made an impact for her. And I don't know that she maybe ever even had that in her short 2 years of life. And so being able to just be there, take the best care we could of her and give her the best outcome, I think is something that just sticks with me. And there's lots of cases like that, absolutely, over 13 years. But she's just always, I can tell you exactly what room she was in the department. I can tell you just so much. I can just still feel like I'm in that room when I'm telling the story, and definitely impactful. I feel like I get a little choked up still, just even thinking about it years later. But again, just blessed to be able to offer her that in that time when she was in such a vulnerable state. At the end of the day, I feel like what I love about emergency medicine is that team aspect. I was talking to someone just recently about just the fact that we're 5 years from the start of the pandemic. It feels like it was yesterday, but I very much remember because I was doing medical direction at the time, I had a temporary office in the parking lot so that I could be by our team while we took care of, COVID concerned or COVID patients in the parking lot in tents. And it was a really hard time, but at the same time, I feel like having those memories and seeing how the entire team came together and how the healthcare world really broke down all the silos. Seeing everyone come together as one team for a common purpose was truly inspirational. I definitely feel like I come back for the people, and whether it's the patients or the team and those people that I get to work around, learn from, have ups and downs with every day is really why I come back. I think it's a field that gives back more than you could ever give it. being in it for, 13 years after training and, 5 years of training in the combined program, I feel like I get much more back from emergency medicine than I could ever give in return. I think for emergency medicine, you've got to like working all hours, all days. It's not all day shifts, not always Monday through Friday. There's definitely pieces of it where you have to sacrifice at different times. But again, the benefit of it is so much more than you give.
The job of an emergency physician can be high octane and high stakes, and no one I know embraces that challenge more than Dr. James Howard. Dr. Howard first learned grace under pressure as a big wave surfer in Hawaii, long before he became a physician. He then trained in emergency medicine in Southern California and took a job in Australia as a flight physician before returning to the US for EMS fellowship.
The first thing that I did when I graduated from residency was I was a flight physician in Australia for the government. And so I was basically tasked with the EMS system when they needed special help. And so I would fly out on helicopters and airplanes and rescue people in the outback. We were sent to a woman who had what was thought to be massive hematemesis. And so, we brought all of our kits there and we flew out to see her, and no one actually witnessed the hematemesis. So it's one of those things like, was it really massive? Was it not? And then when you do this type of medicine, you actually have to decide how stable the patient is and what you want to do. So me being a little bit cautious, I intubated the patient. I put an NG tube in her, and then I also put an arterial line before we transported her. And so we had just full control of her airway and things like that. But her blood pressure was stable pretty much throughout all of that. And then we decided to bring some blood with us too. So we actually, got her loaded up in the helicopter. The portable NG tube container that was going to be the drain for it probably only fit about 200 mLs of liquid in it. And when we got into the air, of course, she had massive hematemesis, probably greater than 500 cc's. And I noticed that her arterial line, the blood pressure went down to like 30. And so we started squeezing blood into this woman as fast as we could. And, we got her blood pressure back up to like 80, 90. And so, you learn in trauma about permissive hypotension, right? And so, me wanting her blood pressure a little higher. So I got it above 100, and then she just vomited a bunch of blood again. And then the arterial line tanked to about maybe 50 or 60 at this point. And we're flying to this tertiary care hospital, and the pilot lets me know, hey, sorry, we got to stop and get gas. So, grace under pressure kind of thing. You're like, okay, well, we need gas. So we had a limited supply of blood, and after the second time that she had thrown up, and there's blood all over the helicopter now because, the 200 cc thing filled up after the first one. It didn't even really work. And so we get gas and we're going, and I literally was squeezing the last bit of blood that we had into her as we were walking into the ICU. I told the story to them, and I said, she needs to go to the OR right now. And they took her to the operating room, and they found that she had a subclavian vein esophageal fistula, and they fixed it and they saved her. And this is kind of interesting also because apparently this person had a history of fistulizing her veins to different places in her body. And nobody seemed to know this before we had gotten there. So, emergency medicine is you're operating in a vacuum, right? A lot of times you have no information, and I was so happy I intubated her and I put that arterial line because that was the saving grace. And like literally just from the training that I had, I just knew this was my first year of practice, and we did that, and we saved so many other people's lives too, just by knowing to expect the worst thing that could possibly happen.
A byproduct of being an emergency physician is the confronting of our own mortality on a regular basis. As Dr. Sierra Bourne relates in the next story, when we see ourselves reflected in the people we care for, it can sometimes be jarring, but it can also help us to feel more connected to why our work matters.
I saw this patient who was extremely relatable to myself, similar age, and for a lot of reasons. And she came in with vertigo. I remember being really concerned, and I fought to get an MRI, which in a hospital like mine, more so then than now, but is really hard to get from the emergency department. We don't do a lot of emergent ones. And I remember getting a lot of side eye and a little bit of, like, what is she doing? No, nobody else would have done this. It was stressful, right? To put myself out there to have to get, this testing for this diagnosis, which I hope it wasn't true, but I really needed to rule out. And I subsequently diagnosed her with a cerebellar stroke, which was, again, kind of shocking given that she just felt personally relatable to me. And so I gave her TPA. That was probably the first time I'd done it in a non-academic tertiary care center, and got her transferred. I called my neurologist girlfriend and was like, can we have a stroke right now? Like, what do I need to be doing differently? Obviously we know all the bad diseases, but on the other hand, just confronting your mortality, right? So there was that aspect of it. When you see yourself reflected in somebody else who's having a stroke, that could impact them for life, debilitate them or kill them, that's scary. That feels real. And I remember calling the hospital afterward, the tertiary care center that I transferred her to, and it sounded like she was doing well. She got discharged, but did a little bit of rehab, and it sounded like maybe a little bit of residual vertigo, but no other major deficits. And then I saw her 2.5 weeks ago in the ER again. Working in a small town, it's not uncommon. So she comes back in, and I remember having this little deja vu when I saw her name pop up, and I went in the room and I was like, yeah, that's her. And she came in for a hand lac, totally minor. And it turns out she remembered me as well. And so we had a little talk about that. And I was like, how did you recover and all this stuff? And she seemed to have remembered it, overall positive, and was really grateful, appreciative. She said that since then she'd had a few MRIs, and the most recent neurologist said that her MRI doesn't show any sign of stroke, and he doesn't believe that she ever had a stroke. And she's like, I know I did. And the MRI before showed it. So that's at least how good her imaging looks. So that was kind of a little bit full circle. And then, I'm 10 years plus into my career from then. So it was just kind of a cool experience. She's had a family since, I've had a family since. So again, it's just this pretty relatable situation. This was one of the cases that gave me confidence in my training, in my diagnostic acumen, having people question me overtly or passively, why are we getting an MRI from the ER? This is emergent stuff only. This lady's young, and to be right and validated. Not that I wanted her to have a stroke, but obviously we got to the diagnosis quickly and helped her out. So there was that component of it where it just clicked as far as actually getting the work done. If it had been in the middle of the night, I wouldn't have even had that available. And it's very rare for people to come back to the ER for MRI, even if you tell them, or to get follow-up. So that was a little lucky. But I think overall, just kind of compassion, which is a big issue in emergency medicine, the burnout, the compassion fatigue, and to see someone similar to you for whatever reasons, or for that reason, your mom, your dad, your uncle, someone sometimes it just takes a little bit of a familiarity to feel that connection when you can't necessarily access those compassion stores all the time. I think it's hard, honestly. I think it's hard because a lot of what we do and experience and remember and beat ourselves up about are the more negative things. I try to count the wins, even if they're small and don't feel as frequent. I think it's important to appreciate them and hold them up to the light.
Readiness for any kind of catastrophe, including natural disasters, is part of the training and mindset of emergency medicine. Dr. Mark Urban was thrown into one of the largest natural disasters in recent history when he was only a medical student, but it helped him understand that he was being called to emergency medicine for the rest of his career.
There's so many cases after doing this for 19 years. But I think the pivotal point for me that pushed me and said emergency medicine is where I want to practice was in med school. In my 4th year in Louisiana, I was at LSU and Shreveport. We had Hurricane Katrina and Rita come through and really devastated the southern part of the state. You know, they always talk about the 100-year storm, Category 5 hurricane, and growing up in Louisiana, I've been through several Category 5 hurricanes, but this one just lined up perfect. So the devastation in New Orleans was pretty impactful, especially when the levees collapsed and the flooding. They were ill prepared for getting patients out of the city, so there were a lot of deaths. I think there was one documented LTAC that had several patients in nursing homes that just had patients abandoned and died. I was set to rotate through the emergency medicine residency in Baton Rouge right after Katrina. And so I went down to do my rotation, and it was absolutely incredible. One, the devastation, but then two, the lack of access to resources and how that impacted the communities. I was like, wow. And just the way that the emergency responders, the emergency departments kind of all banded together to take care of these folks was hugely impactful for me. And it kind of has driven where I've gone with my career, particularly with medical director for our county agencies here in Ada County, as well as my military time joining the Air National Guard and being a critical care air transport team member, as well as a flight surgeon, because we train to respond to those things. And after living it as a med student and seeing what that was from a response and how it impacted communities, like I want to be a part of that and make my career about serving the community. And that's really where it's been driven. I always wanted to join the military. But my wife comes from a military family, and we met in med school, and I was signed up to join the Army, and she said, no, we can date or you can do that. Now married almost 20 years and 2 kids, I think I made the right choice. I explored it again in residency with the Arizona National Guard based in Tucson. She said no. And then we moved to Idaho. I explored it again. She said no. And then for whatever reason, about 5 years ago, she told me that if I could do the specific thing that I do now, which is the CCAT or Critical Care Air Transport Team, she's like, you would really enjoy that. Then I could do it. And I'm 5 years in. I just promoted to Lieutenant Colonel and absolutely love it. Love serving the community, our country, and the medical mission. What we do for our medical mission and serving our communities is hugely impactful. There are tons of opportunities, especially for emergency physicians in the Air Force. I think there are more opportunities for jobs that we can do in the military. There's ground surgical team, which is a really cool mission set. We have a ground surgical team here, our critical care teams, the CCAT, as well as being a flight surgeon, which is aerospace medicine. A lot of that is occupational health, but in all honesty, I've actually enjoyed that to a degree because it's something different and I get to do that part-time, and I really enjoy keeping our flyers flying, and part of it I get to go fly. But there are many opportunities open to emergency physicians in the Air Force that really can change your outlook. What it's really helped me with on the emergency department side is that mutual respect for the people we work with, because part of the training with CCAT is we have to learn how to run the vents, run the pumps, program pumps, mix drugs. You have to be cross-trained on all of the different jobs. And it was eye-opening for me what the nurses do. And so now when I'm sitting at a computer putting in orders, I realize how quickly those tasks add up. And then in my regular job, I will go in and do my own EKGs as they're doing the line start. I will help set pumps up. It keeps my skills up, but it also shows a mutual respect for, hey, I get it. I just put in a ton of orders on this critical patient. What can I do to offload that other than stand back and go, hey, why aren't my orders done? So it really has helped me with crew resource management, CRM, as well as just that mutual respect for the team approach to critical patients. I know it's made me a better provider. It's actually been rejuvenating because burnout is real, but it has really helped me kind of find my second wind 14 years out of residency.
Dr. Jennifer Lumen is an emergency physician with disaster medicine fellowship training, but even before her fellowship, she has long been committed to natural disaster response around the world. During her tenure as part of a DMAT team based out of Portland, Oregon, She responded to many crises, including the 2004 Indian Ocean tsunami, one of the deadliest ever recorded.
One of the peak patient experiences that I had was probably in Banda Aceh after the tsunami. And I was working with a team kind of in the field, literally in the field of the disaster zone. We'd set up in a little house that had been decimated, but at least had shelter from the sun. And this woman came up to me who was complaining about her C-section site. She'd had a C-section before the tsunami, and she was just in tears about something's wrong with the C-section site, something's wrong with my wound, you need to help me fix the wound. And I did a full inspection, physical exam. The wound was healing great, the incision looked fantastic, and I just sat her down in a chair to try to figure out if there was anything else going on or what exactly she was worried about. She ended up breaking down and telling me that right before the tsunami, she gave birth to a little girl and had a C-section. And when the tsunami hit, she gave the baby to her husband so that he could run to try to get to higher ground. And because she knew with this wound and having had a recent C-section that she'd had a surgical site, she couldn't run as fast. So she gave the baby to the husband to try to escape. And the baby and the husband perished, and she somehow survived. She got pinned up against some debris and was able to climb up on logs, and she survived while her newborn infant and husband perished. And it was really very heavy for me to realize that a lot of her pain, which we see every day in the emergency department, often is psychological, has a lot of backstory of what's going on for them emotionally and physically. And I think as a doctor, that's a powerful thing to be able to be part of someone's life and help them realize the layers that go into pain and illness and grief. So that's one of the innumerable cases, but one that often sticks with me. And it was great because I got to help get her some resources, which we had in the disaster scenario with Doctors Without Borders, and get her some mental health support and grief counseling and stuff for that. But yeah, it's a heavy job, emergency medicine. You see all layers of it. You have to have life balance. You need to do some sort of mindfulness, some sort of wellness for yourself. You need a good community of friends, colleagues, like-minded people that you can hang out with and talk to, especially on the hard days. You got to do something like meditation or yoga or exercise where you get to burn off the stress and find balance again. Because we live in an extreme environment, and even the world is an extreme place. You got to make sure you look after your own health. You got to eat properly, you got to sleep properly, and I know that's hard to do when we're shift workers. It's really brutal when you're in the throes of it and doing multiple night shifts in a row, but you have to find a way to balance your life.
We all have that one case, or perhaps more than one, that we will never forget. Often that case can be practice-defining and colors the lens we see things through for the rest of our careers. Dr. Jacob Lieb had a case like this shortly after finishing residency, and 15 years later, he still carries it close to his heart.
The case that probably stayed with me the longest since I left residency, which was 15 years ago, was I was out of residency maybe a year and a half, 2 years, and a case came in that I had never seen before. I had heard about it, and you study about it for your boards and everything. But it was a 18-month-old came in during the respiratory season. He had seen his primary care physician that day and diagnosed with a URI. Everything was good, vitals were fine. And then probably about 3 a.m, his mom brought him in, and he was literally lethargic, limp and floppy. His mom carried him in because he had just decompensated through the evening, and he came back, and we got him in our resuscitation bay. And thankfully, even though we are a small hospital, our nursing staff at night is phenomenal. And I was working with one of probably our best nurses, and she recognized immediately that he was extremely sick. And I was with another patient, and she came and got me. And I went into our resuscitation bay. And when I looked at the monitor, he was extremely tachycardic, about 160, and his sats were in the 50s. And so I'm trying to get as, real quick history as to what's going on. And the mom said that he had URI and everything had been good. And then he went to bed. And when she went to check on him, he was like this. He was floppy, minimally responsive. And so my nurse was able to get an IV like immediately. He was laying on the bed. He would follow commands a little bit, but he was really struggling. So we got the IV put in. I listened to him. He was kind of wheezy everywhere, so we got him on some high flow oxygen and started him on a epineb. And his sats improved pretty significantly. He started crying and kind of moving around a little bit. So I gave him some ketamine to kind of try to control the situation. I knew we were going to have to probably take over his airway for him. And with the ketamine and the racemic epi, his sats were good. So I bought a little time and started doing the typical blood work, chest x-ray and whatnot. And so saying we have specialties here, we have pediatrics, but we don't have a pediatric ICU. The nearest pediatric ICU was in Denver, which is 6 hours away by ground and hour and 45 minutes by flight. And the transport had to come from Denver Children's up to us. I called to get him accepted down there, and I explained the situation, and we came to the agreement that he needed to be intubated before he was transported. And luckily his pressures were decent. I gave him a little bolus of fluid. And what I wanted to do, but I knew wasn't possible because he was pseudo-stable, was leave him on just the mask and ketamine drip and transport him that way. But I knew, with the flight and the transfers and stuff, that I couldn't do that. So I get ready, get everything set up to intubate him, and he's on the monitor. We get it all set up. I do a little bit of pre-treatment. His heart rate goes up a little bit, and as I put the laryngoscope blade in his airway, I can see the cords. Everything is good. I'm getting ready to pass the tube, and as the tube hit the back of his tongue, he coughed, and all of a sudden his entire posterior pharynx, just this white stuff showed up everywhere. He hadn't vomited. It had come out of his airway, and I had no idea what it was. I was like, this is just wild. And I could just see bubbles. I attempted to intubate him blindly because I was there, and I ended up getting in the esophagus the first time, pulled out, suctioned. And during that, I had a really good ICU trained nurse who was our nurse supervisor, who was there, who responded to the critical call out for help in the middle of the night. And he just over my shoulder starts saying his heart rate's going down. He's 90, 80, 60. And so we started CPR when he got to 60. I'm still trying to get the airway. Sats were still fairly reasonable because we had pre-oxygenated him so well. Suctioning just all this white stuff out of his mouth. Attempted to intubate him again, and I was just meeting resistance all over the place. And then pulled out, suctioned, CPR's going on, and was able to finally intubate him. Got the airway, but we're now coding him, doing CPR. He went into PEA arrest for probably 20, 25 minutes. And during that period of time, this is, I think about this case every time respiratory season shows up, because I had listened to a EM rap probably about a week before about the pediatric arrests during intubation. And I remember there was a saying during that when you go to intubate a kid and they have that Brady arrest, it's almost impossible to get him back. And that just kept going through my head. I was like, he arrested, I'll never get him back. And we coded him several rounds of epi. because he was critically ill and I had a little bit of time before we did it. I had all the doses drawn up. I don't have inpatient pharmacy. My nurses were drawing up the meds. We're giving him epi, trying to get him back. His heart rate was in the anywhere from 30 to 60, doing CPR. And as this was going on, his parents were in the room. His mother was pregnant with his sibling at the time. And she and the husband were sitting behind me. And I remember we're coding him and the mom just started crying. I just thought the little kid was going to, we weren't going to get him back, but we ended up getting him back. And so get the pulses back. We got antibiotics on board. Once we got pulse back, his pressures came back up. We didn't have to put him on pressors. Cultured him up, swabbed everything we could. And then I had to do, pediatric critical care for about 2.5 hours. And then they showed up and he was able to go get transferred. And he went down to Denver and was in their PICU for about 1.5 months. And there were several discussions about removing life support because his functional MRI wasn't good. But they were doing some spontaneous breathing trials and he came out of it and was able to hold his own. And then, they were able to wean him off the vent after a pretty extended period of time. And he ended up doing pretty well, was down there in rehab for 3-4 months. And it ended up, what he had is he had bacterial tracheitis, which I had never seen before. You hear about it, you read about it. He ended up having the flu. He had adenovirus. He grew out, I think, staph out of his trachea. And then he had 3 or 4 other things. He ended up having 6 pathogens cultured out. He was down in rehab for a long time. And then he came back and, his family's working people. They don't have, significant finances. And so we had a huge benefit for him. And I was able to see him on kind of a Zoom call with his mom. And then about a month later, I ran into him in a grocery store. And his only deficits were a little bit of learning disability and some vision because his brain swelled a little bit and he had some occipital injury and he had a little bit of visual cortex injury and he had to wear some glasses. And most of his stuff has resolved. The neuroplasticity of kids is amazing. And so he survived. But every year during the respiratory season, I think about him and how tenuous someone can be to be in their pediatrician's office, look fine, like they have a cold, and then, deteriorate so quickly. And, we study bacterial tracheitis. I knew what it looked like, but I will say when he came in, it wasn't on my differentials. That's what he had. And when his posterior pharynx just filled with pus out of his trachea, I was just taken aback and it was terrifying. But I respect the sniffles during the winter every year. The fact that he did good and he survived was one of the most amazing things to me. I thought for sure it was going to be a bad outcome and I didn't sleep for a week. Just felt horrible. But he ended up doing okay. And so I feel pretty good about it now. But for a long time, it stuck with me. And every respiratory season, I think about him every year when it starts to make sure that I'm ready to do what I got to do when those guys come in the middle of the night. Thankfully, I still like going to work every day. Even during the pandemic, when it was tough, I liked going to work. I had an episode of burnout during the pandemic where when I would drive to work, I was still happy to go to work. And then when I would get to work, something would make me mad and I'd be angry within like 10 minutes of getting to work. And so I struggled with that. The medical atmosphere in the United States is challenging with all the changes and the more work requirements we have and the CMS criteria and all the things that you have to do, documentation, it can wear you down. And, we call it the pebble in the shoe. All the little things that just make your shift harder. Just work every day to try to get rid of those pebbles and keep going. I still love emergency medicine. In the last few years, I guess I've taken an interest in palliative care. I don't think I necessarily thought much about it previously, but it's the little things that you can do for people to intervene in their life and really help them. You know, a cancer patient that's got tons of pain, just helping them alleviate their pain. So I find little victories help me get through. It's not all critical care. I love critical care, but even the smallest things, just relieving anxiety about a diagnosis that they think they have. The medicine aspect of it, you know, if you train well and you learn it, that's kind of an easy component. It's the personal interactions that'll make your job have some longevity. And when you go through a period of time where you don't feel like you're having any of that, just remember that even the smallest aspects of what you do can help somebody.
I couldn't say it better than Dr. Jacob Lieb. Sometimes even the smallest aspects of what you do can help somebody. The stories gathered here are all different, but they have a common theme. Helping people is at the heart of what we do as emergency physicians, and staying emotionally connected to that aspect of the work is paramount. It's why we all went into medicine in the first place. I am grateful beyond words to my friends and colleagues who shared their stories. Thank you for lifting us up. Your commitment to caring for others, your tenacity and your perseverance represent the moral contract we have with society as doctors to keep fighting for our patients. To my fellow emergency physicians at ACEP 2025, if this inspired you, please visit ACEP's Answering the Call installation. We can't wait to hear your stories too. Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare through conversation. If you liked what you heard today, please follow this podcast and share it with your family, friends, and colleagues. By spreading awareness, we can bring about change. You can also connect with me on Instagram at drjoymd. That's DOCTOR Joy MD.